We are going to be palpating in two areas that are sensitive areas to palpate, and so especially if you are palpating cross-gender, you're going to want to make sure that you get permission again to do so, okay? So Aubrey, I'm going to start by finding some structures on the front of your chest along your sternum, okay? So this is, your sternum is your breastbone where all of your ribs come forward into the front and connect, and I want to be able to check those connections between the ribs and your breastbone to see how those are connected, okay?
Okay.
Is that okay with you?
Yeah.
I kind of told you and didn't ask, so that's not good.
Yeah. No, it's good.
Okay, so we start with the clavicle, we go to the suprasternal notch, which we've already palpated. The manubrium is the top part, okay, and then rib 2 is going to connect to the manubrium. If you come a little bit further down, you're going to feel so sorry you guys, a ridge right here. And this is going to be between the manubrium sterni and the body of the sternum, okay? It is super warm. So I come down and I feel that ridge. I can palpate down along the sternum all the way down till we get to xiphoid process, okay? So we can get down there. Now we do want to be able to palpate those costochondral junctions, so you want to just go lateral to the sternum. Now again, you do not want to palpate over clothes, so if someone's in a gown or a robe, you're going to need to put your hand down underneath the gown or the robe to get to these areas. Now if someone, particularly if someone's been in a car accident, you can have a dislocation of a rib, and so you want to be able to check to see if the rib is anterior compared to the other one. So a lot of the rib palpations I would actually do sitting down. So if I were palpating here, again, if I went back, I'm on the clavicle, the sternoclavicular joint, the suprasternal notch, the manubrium, the sternal angle, and the body of the sternum, and then I can come along laterally. Go ahead and breathe for me. Take a deep breath in and back down. Good. Breathe in for me. And I'm just looking, just like I did for the transverse processes of the cervical spine, I'm wanting to see if one's more anterior versus the other one. I'm also checking to see when she breathes, do I see more movement under one finger than the other, okay? And I can go down and check all the way down, all right? Someone may have rib pain posteriorly. To confirm that it's a rib and not a vertebral segment, you'll want to check it anteriorly as well. So for rib problems, you need to be able to check the ribs both anteriorly and posteriorly, okay? I think that's it on this slide. So we're going to get down to pelvis.
Dr. H,
Yes.
for sternal angles for testing, and what next tests would we do for those?
So I would like you to start thinking about those, and I'm happy to go over your list, but I'd like you to start thinking about those. So like what muscles attach there, what landmarks would you use, those kinds of things, okay? Because what I don't want you to do is just memorize things. I want you to start to think about those next tests, okay? But I'm happy to talk about those one-on-one or after you've thought about it a little bit I'm happy to confirm those for you, okay?
What is the sternal angle and the sternal notch?
No. So the sternal notch is here, suprasternal notch. The sternal angle is right here, which is between the manubrium sterni and the body of the sternum. And when you palpate it a little bit later on each other, you'll feel that ridge, okay? And that ridge is important because that is, you'll know which ribs are attaching, okay? All right.
Bless you.
And then xiphoid is here. So most of you have done, well, all of you have done CPR. So normally you're using xiphoid as a landmark for hand placement. Okay. Now remember that for our lower ribs, this is all cartilage. Okay, and that it's not osseous. Okay. Okay. So for the next one, we're gonna do anterior pelvis. Right. I'm sorry, what? Did you say something? Okay, So for the pelvis, this is one exception where we do palpate over clothes and we do not go under someone's garments for the pelvis, okay? You do want to, like most clinics are going to have cotton shorts that someone can change into because you don't want to palpate over denim. It's going to be super hard. It looks like everyone dressed really appropriately today. So
almost everyone.
I got shorts in my locker. I'll go change.
okay. Oh, you're ticklish? Oh, great. Okay. So to find the iliac crest, I'm going to use the radial side of my second digit, and I'm going to come in, okay, and I'm right on top of her iliac crest. My thumbs are going to fall pretty close to her ASISs. So if we look at the skeleton, I'm coming in and I'm going just above her iliac crest so that I know where I am. And then my thumbs drop down and they land right on the ASISs. Okay, so these are the bony prominences. The ASISs we're going to use to see, because the ilia can rotate relative to one another, and so we'll use these to see if we have one that's rotated on the other. So here we're looking to see if one is more superior than the other. Okay? You can also have a flare of the ilia, but you will cover that in spine class. So you can also look the relative distance to the middle. Okay? But right now I would like you to look more at superior, inferior. Now, from the ASIS, there's another bump down here, which is the AIIS. So the anterior inferior iliac spine. And this is where your rectus femoris attaches. Okay? Now, this is going to be a little bit deeper. Okay? So if you're ticklish now, this is going to be even more fun. Okay? So we've got our pelvis here. Now, if I look at Aubrey's ASISs, her right is a little bit inferior. Okay? Now, if I'm going to find her AIIS, okay, I'm just going down a little bit in inferior. I charge double for laughter. Now, if someone is tight or has tight hip flexors, you may need to use the wedge. So I'm going to slip this under your knees.
Do I?
There you go.
Okay.
Well, you're laughing, so that makes it a little bit
sorry.
tighter.
I can't help it.
It's okay. So usually if people are ticklish, which is going to happen, wait till we get to feet. People really don't like having their feet touched. So don't lighten up your touch because that will be even more ticklish. Be more firm, okay? Now that's not working for Aubrey, but for a lot of people, if you're just firmer, that actually helps them stop laughing, okay? Okay, so we've got our ASISs here. And then that's her AIIS on her right side. Now, if I wanted to confirm that that was, what I'd like you to do is try to lift your knee up off the wedge. There you go. Oh, so I was off a little bit. Do it again. Because we're looking and relax. So we find that rectus femoris, and then we can go up and find that AIIS. Okay? Now, there is another place that we need to be able to palpate is the pubic symphysis. Okay? And so if the ilia are rotated, or if the pubic symphysis itself is stuck, they can have a lot of pain. And it's a part of the pelvis that people are pretty, PTs tend to overlook. And if you treat it, it can make a world of difference. So we need to be able to see if the two pubic bones are even to decide if we're going to treat a pubic symphysis dysfunction. And it is, again, a really important thing to be able to do. You can imagine that this is a pretty sensitive area for people, and so if I suspect something is wrong with their pubic symphysis, I will go and get the skeleton. So we have a skeleton that's just the spine and pelvis. Bring it in, explain what this pubic symphysis is, explain what I think is going on, and have them help me find it. Okay? So,
I'm so bad at this.
when I looked at your pelvic bones here, it looked like one was rotated compared to the other one. And what I need to see is if this joint right here is out of whack or not. So what I need to be able to do is find these two bones and see if one is more level than the other. So what I want you to do is help me find that bone. So what I'd like you to do is take the palm of your hand down for me until you hit that ridge, and then I'm gonna take a look for it, okay? Yeah, you can get rid of this. Yep. Just like that.
Yeah.
Yep. Are you on it?
Yep.
Okay. Thank you. So now I'm right there on the pubic symphysis, and I'm looking to see if one's higher than the other, and they look the same. So the fact that your ASISs aren't the same means that your bones are twisted, but that your pubic symphysis is level. So we know we don't need to treat that. We know we need to do something else. Okay? So that's how I would handle that, but have the patient find that first.
Can we do that in our practical?
Absolutely. That's how I would do it in the clinic. It also makes the patient much more comfortable because they know what they find the bone, and then you're coming in on it so that you're not hitting anything else. Okay? When the video's not rolling, I will tell you about my PT story, about the pubic symphysis and why I've developed this process for pubic symphysis. Okay? The inguinal ligament is going to go from the ASIS to the pubic bone, and so that's right in the crease of your legs. So if you've heard of the inguinal hernia, that is where that ligament has actually herniated, and so it's torn, and some of the abdominal cavity has come through that. So the inguinal ligament, again, I'm actually gonna, there you go. So we're gonna start at the ASIS. Now this is a ligament that crosses this way, so we're gonna go cross fiber, okay? And that's your inguinal ligament right there, okay? Now the inguinal ligament is important because just inferior to it, there are going to be inguinal lymph nodes, and we're also going to be finding a femoral pulse there. But I don't think we do that on this section, I think we do it with the hip. So we'll use the inguinal ligament later. The linea alba is the fascial divider of the rectus abdominis. So for those of you who have a six-pack, of which I do not, that center line is the linea alba. That's important because people who have had babies, that linea alba actually separates to allow for room for the fetus. And so in people who are postpartum, sometimes the rectus abdominis does not come together, and there will be an accentuated linea alba. Now, so this is going to be particularly important for people, women, postpartum. That said, in our very first class, we had a guy who had a very distinct linea alba and had a valley there. So you need to be able to palpate the linea alba because there are specific exercises we can do for these postpartum moms to help bring their rectus abdominis back together. Okay? So that's going to be, do you mind if I lift your shirt up just a little bit?
Fine.
So that's going to be just right down the middle. And can you just lift your head off the table? And so I'm looking for a separation, and there's not any. Okay? That's good.
Shoot.
You want there to not be any. Now, for the abdominal aorta, that is your strongest pulse. Okay? So we have the abdominal aorta, and that's actually why pregnant women can't lie on supine, because the baby will actually put pressure on the abdominal aorta. So you should be able to just put the hand on the belly, and you'll feel a very, very strong pulse.
Is that the pulse when you feel when you're like laying down in bed?
Yeah, exactly. Okay. So I think that's all on those two slides.
I don't have one.
Okay.
I'm dead.
So the
Sorry,
the iliopsoas starts in the lumbar spine and then attaches to the anterior rim of the iliac crest and then comes down and attaches onto the femur. And I don't know, so it's a hip flexor. So I don't know if any of you have had any deep tissue work done on the iliopsoas. So it's not necessarily comfortable work, but it's super important, and if you do it correctly, you can really help people a lot. But it requires you to go over the rim and press through all of the soft tissue to get to the iliopsoas. Okay? Jamie's saying you had it done?
It's painful.
Yeah. Yeah. So what you need to do is use our techniques that we've talked about for palpation. And so you're going to go over the iliac crest and you need to slowly change the angle of your hand. If I just went, she's gonna tighten up and not let me work through all of those structures. So it's really important that you start with a hand that's really pretty flat and slowly work it in, and you're going to just go back and forth nice and slow. If you get resistance and the muscles contract, back out of it, and then start working down again. Okay? But I'm only a third of the way there. So I can do it in someone else and go deeper if you'd like, but that's how you would get to the iliopsoas, and that is the iliac fossa. Okay? All right, now we've covered everything on the page.